Giant cell arteritis and PMR represent overlapping manifestations of a shared inflammatory disease spectrum. Making careful evaluation is essential to ensure timely diagnosis and appropriate management. Thank you, Dr. Nigat, for sharing your valuable feedback with us today. We're grateful for your contribution to our conference. Despite significant advances in therapeutic options, suboptimal adherence to long-term treatment remains a major barrier to achieving sustained disease control in rheumatology. Factors such as medication side effects, patient perceptions, and healthcare system challenges contribute to poor compliance. Addressing adherence is therefore essential to bridge the gap between treatment efficacy and real-world outcomes, ultimately improving patient quality of life. We're pleased to introduce Dr. Ashar Ahmad, a dedicated and accomplished rheumatologist. With MRCP and specialty certification in rheumatology from Royal College of Physicians, UK, he brings strong international training and expertise. Currently serving as Associate Professor at Dr. Ziauddin Hospital, Karachi, Dr. Ashar is committed to enhancing patient care and advancing clinical practice. We look forward to his valuable insights on this critical issue. Please welcome Dr. Ashar Ahmad on the stage.
So, good afternoon, dear colleagues. It's indeed a great privilege and an honor to stand in front of you, and thank you to Dr. Aflaq and the rest of the organizers for inviting me to deliver this talk. The thing is that no matter how much rheumatology has advanced, and all day we've talked about different treatment strategies, all the newer options that are available, and treat-to-target strategies, dose reduction strategies, but all of that will fail if your patient doesn't take the treatment. So, adherence is a major issue. Basically, we'll just go through what adherence is, what do we mean by the concept, and basically what are the factors behind it, what do the studies say about it, and what can be done. So this key paper highlights that medication taking behavior has been inconsistently described over time using terminologies like compliance, concordance, and adherence. Now, Horn and colleagues here, they argue that the traditional idea of compliance is actually outdated and should be replaced with more patient-centered approach. Because compliance is basically when the patient passively follows the doctor's orders and is sort of a more paternalistic view. When you use the term adherence, then this is a little bit better, which means that the degree to which the patient will follow the agreed treatment plan, but again, this is more clinician-driven. The most important concept is actually concordance, which is a shared decision-making process between the doctor and the patient, and it tends to recognize the patient's beliefs, preferences, and there's a degree of autonomy in that decision-making process. Another paper by Vrigens and colleagues addresses this long-standing problem of inconsistent terminology in medication-taking behavior. The authors then proposed a standard taxonomy that defines adherence as a dynamic process rather than a single behavior. It's divided in three phases: initiation, implementation, and discontinuation. Initiation, obviously, is the process of starting the prescribed medicine. Implementation is how closely the patient's actually following the dosing, the prescribed dosing regimen over time. And discontinuation is when the patient actually makes a decision to stop the medication completely. Additionally, they also define persistence as the duration of time from initiation until discontinuation. So this framework actually helps to distinguish different types of non-adherence, whether the patients actually never start, they do not take the medicine correctly, or whether they stop early, and allows for more precise measurement and more targeted interventions. Medication non-adherence also has a major economic impact, costing around 125 billion euros annually in Europe and about USD 100 billion in the United States. In the UK alone, it contributes to approximately 500 million pounds per year in additional NHS costs. and this is due to hospitalization and extra treatment. This highlights that despite advances in therapy, non-adherence still remains a key barrier to effective disease control. And particularly, this is true for chronic conditions like like rheumatic disease in general. So in rheumatology, it's actually the perception that drives adherence rather than the prescription. Medication adherence varies widely and can be strongly influenced by patient beliefs, including the perception of treatment effectiveness, its necessity, and the patient's actual confidence in therapy. Now, reported adherence to biologic DMARDs ranges broadly from 30 to 89%, and this is across various studies. In the ARCO study, for example, adherence to subcutaneous biologics and oral DMARDs was relatively high at about 85.7%, but this study also suggested that simpler dosing schedules, particularly less frequent administration, are associated with better adherence. Overall, the findings highlight that beyond clinical efficacy, patient perceptions, treatment satisfaction, as well as the convenience of taking the medicines are key determinants of adherence in rheumatic diseases. Another 6-month prospective cohort study by Balsa et al. Highlighted that adherence is not determined by a single factor, but it's rather influenced by a combination of patient-level, treatment level, as well as healthcare system-level variables. The key findings showed that psychological factors, such as patients' beliefs, again, we've talked about this, the perceived necessity and concerns about adverse effects were strong predictors of adherence. Clinical factors alone were less predictive as compared with behavioral and perceptual variables. At the treatment level, simpler and more convenient regimens were associated with better adherence. And at the system level, stronger patient-physician communication, follow-up support played adherence, supported the adherence outcomes over the 6-month period. And again, overall, this study reinforced a multi-level model of adherence in rheumatoid arthritis, where psychological, therapeutic, and healthcare-related factors interacted to determine the medication-taking behavior. So as we look at these factors in more detail, we see that patients with rheumatoid arthritis have a significantly increased risk of mental health disorders, and especially things like depression and anxiety. Now, this was a UK-based cohort study by Jacob and colleagues, which showed that approximately 30 to 36% of patients with RA developed depression within 5 years of diagnosis, with a higher risk observed in women as compared to men. This highlights that depression is a common as well as early complication in rheumatoid arthritis. In addition, a qualitative study by Mackin and colleagues explored anxiety and depression in RA patients, found that these conditions are frequently under-recognized in clinical practice, and this is because patients tend to face stigma and perceive that clinicians prioritize physical disease over mental health problems. Again, barriers to recognizing mental health disorders in clinical practice include limited consultation time as well as fragmented care, while improved communication and continuity with healthcare providers can be associated with better management of psychological problems. Overall, both of these studies emphasize that depression and anxiety are highly prevalent in rheumatoid, often go undetected, and strongly influence both disease burden as well as healthcare system, as well as the healthcare delivery. Now, the reason this is important is because depression in patients with rheumatological disorders is associated with reduced motivation, a sense of hopelessness, and impaired self-care. And this can then lead to poor medication adherence, missed appointments, as well as overall lower engagement with their treatment process. Depressed patients are about 2 to 3 times more likely to be non-adherent. Anxiety can also negatively impact adherence by increasing the fear of side effects, particularly with biologic and immunosuppressive therapies. And this can result in both delayed treatment start as well as premature discontinuation. Treatment fatigue can often develop in patients on long-term therapy, especially DMARDs, whether they're biologics or synthetic or the targeted synthetic variety, and this can lead to psychological exhaustion. This can again reduce the motivation to continue treatment, especially in chronic lifelong conditions like rheumatoid arthritis. The perception of illness can also play a key role, as patients tend to underestimate the disease severity, or they may have doubts about the effectiveness of their treatment and are then more likely to reduce adherence or discontinue therapy. Overall, addressing psychological comorbidities is absolutely essential to improving adherence, disease control, and quality of life in patients with rheumatic disease. Economic factors obviously play a major role in determining whether patients can initiate and maintain long-term therapy. This is true in places where the expenses are out of pocket, as well as where they are funded either by charity or by governments. And a key issue is the high cost of advanced therapies, particularly biologics and targeted synthetic DMARDs. As we know, these treatments are often required long-term to maintain remission or low disease activity, and this significantly increases the burden on patients financially. As a result, cost can become a direct barrier to treatment initiation as well as its continuation and adherence in routine clinical practice, and this is something that we all see on a day-to-day basis. So when applicable, and this is especially true for our patients with corporate cover, insurance and reimbursement policies can become key determinants of access to advanced therapies in rheumatic diseases. Limited coverage can delay treatment initiation, can also interrupt ongoing therapy, or force patients to switch to less effective alternatives due to just cost constraints. The same thing applies to patients who access therapy through charitable funds, whether these are government or whether these are private. In addition, medication availability in Pakistan is another major barrier because we are a resource-limited healthcare system. Biologics and even other DMARDs may not be consistently available due to supply chain issues, and this can also lead to treatment interruptions, discontinuation, and subsequently flare-up of the long-term disease. So economic barriers are especially pronounced in low to middle income countries where patients often face high out-of-pocket healthcare expenses and limited access to biological therapies. In addition, weaker healthcare infrastructure can restrict the regular follow-up and consistent availability of the medications. Clinically, these financial constraints then contribute to poor adherence, discontinuation of treatment, and suboptimal disease control, which ultimately increases the disability and the long-term healthcare costs down the line. Therefore, it's important to address economic barriers through improved insurance coverage, patient assistance programs. Broader access to affordable therapies is also essential to optimize adherence and long-term outcomes in rheumatic disease. So this is actually data from a conference abstract which was presented at the ACR Convergence 2023. The All of Us cohort is a large NIH-led database which combines the healthcare records and patient-reported data from over 1 million individuals, and this is designed to study real-world health outcomes. This slide actually shows the financial burden of medication in patients with systemic rheumatic disease, and this is compared to those without. So about 18.2% of patients with rheumatic disease did not obtain their prescriptions due to cost, versus 11.6% of those without rheumatic disease, and this highlights a clear gap of affordability. Cost-related non-adherence is higher across all the rheumatic disease groups, particularly in conditions like lupus and ankylosing spondylitis, according to this data. Many patients were also using certain cost-cutting strategies, such as skipping doses or delaying their prescription refills, and this may also impact their disease control. And this is also likely compounded by overall lower socioeconomic status in patients with rheumatic disease as compared to those without. Clinically, this emphasizes the need to consider affordability when prescribing and to actively address barriers to adherence. Again, this cross-sectional study by Kumar et al. Examined the sort of determinants of adherence to DMARDs, and they compared whether there is there's a racial and ethnic difference there as well. So they compared a white British and a South Asian population with rheumatoid arthritis. Now this study highlighted that adherence is influenced by a combination of demographic, cultural, as well as psychological factors, and the key findings showed that beliefs about medication, particularly the perceived necessity and the concerns about harm, these were all strong predictors of adherence in both ethnic groups. However, cultural and language difference also influenced understanding of disease and treatment. For example, with South Asian patients being more likely to report communication barriers and differences in health beliefs, and this affected their adherence. The study also emphasized the importance of doctor-patient relationship, their trust in healthcare providers, and the effective communication in improving adherence across both populations. Overall, the findings tend to suggest that while core psychological drivers of adherence are constant, the cultural context and communication also play a crucial role in shaping medication-taking behavior. Getting to the specific drugs, this study evaluated adherence to methotrexate in rheumatoid arthritis patients, and it found that while the overall adherence was generally good, many patients actually had limited knowledge about the drug and its side effects, and over half of them experienced side effects. Better adherence and awareness were associated with factors like higher education, age, and longer disease duration, and were linked to improved quality of life. So still sticking to methotrexate, this prospective cohort study examined adherence to methotrexate in early rheumatoid arthritis over a period of 6 months. A significant proportion of patients were non-adherent early in the treatment, showing that adherence issues begin at initiation. The strongest predictor of non-adherence was patient belief about the medication, particularly their concern about side effects and doubts about the actual need for treatment. Clinical factors like age and disease severity were actually less influential. Non-adherence was mainly intentional, and this was driven by concerns about harm and the perceived lack of benefit from methotrexate, rather than forgetfulness. Overall, the study highlights that improving adherence requires addressing patients' beliefs and concerns through education and shared decision-making rather than just focusing on disease activity. Again, this real-world study shows that switching methotrexate from oral to subcutaneous tends to improve adherence, with higher adherence increasing from about 42 to 51%, and nearly 60% of patients improving or maintaining strong adherence. Now, importantly, this translates into better clinical outcomes, with remission or low disease activity more than doubling to over 50%, along with improved quality of life, even without the need to escalate dose, just by switching the mode of therapy. The key message is that changing the route of methotrexate is not just a pharmacokinetic decision, it's a practical strategy to improve adherence and outcomes in routine clinical care. So this study actually evaluated whether the FDA black box warning on JAK inhibitors affected medication adherence in rheumatoid arthritis patients as compared to TNF alpha blockers. And the overall message was that adherence and discontinuation rates were similar between JAK inhibitors and TNF inhibitors. And importantly, the black box warning did not significantly impact adherence or persistence. This real-world study evaluated adherence and drug survival of biologics and tofacitinib in patients with rheumatoid arthritis, including both treatment-naive and treatment-experienced groups. And overall, adherence was generally good across therapies, but notably, about 50% of treatment episodes were discontinued or switched. And this highlighted challenges with long-term persistence. Drug survival actually varied by agent. Some biologics like adalimumab, certolizumab, and rituximab showed higher discontinuation risk as compared to etanercept, suggesting differences in real-world durability. Patient factors also mattered because older age was associated with actually better persistence, while comorbidity and healthcare utilization predicted discontinuation. Overall, the study emphasized that beyond efficacy, real-world drug survival and patient factors are key in treatment selection and personalization. So this prospective study evaluated the adherence to subcutaneous anti-TNF therapy in rheumatoid arthritis patients and specifically examined the impact of injection site experience. Over a 12-month period, around 22% of patients were non-adherent, indicating that adherence remains a significant issue even with biologic therapy. Importantly, injection site pain and skin sensation were strong predictors of adherence, highlighting that the physical experience of injecting oneself plays a critical role in treatment continuation. Other factors influencing adherence included age, disease activity, and comorbidity burden, with older patients and those with higher disease activity showing a better adherence. Interestingly, there was no significant difference in adherence between the different anti-TNF agents, which suggested that the patient experience rather than the actual drug choice might have been the driving factor here. Again, another cross-sectional study by Joseph Smolin and colleagues evaluated real-world adherence in patients with RA, psoriatic arthritis, and ankylosing spondylitis. Now, across rheumatoid, psoriatic, and ankylosing spondylitis, adherence was consistently higher with TNF-alpha blockers as compared with conventional DMARDs or NSAIDs. In rheumatoid, adherence was highest, which was over 75%, in patients receiving combination therapy with TNF blocker and a conventional DMARD, suggesting that patients are more likely to continue treatment that is providing better symptom control. The difference was especially marked with ankylosing spondylitis, where conventional therapy had very low adherence. So to NSAIDs, people showed very low adherence. Overall, the key message was simple. Patients are more likely to stick to treatments that are more effective and better tolerated. And so improving adherence is not just about counseling, it also depends on choosing the right therapy. Another cross-sectional survey showed that most biologic-naive patients prefer IV over subcutaneous biologics, regardless of their gender. However, the age influenced their preference, because patients that were between the ages of 40 to 60 tended to prefer the subcutaneous therapy, probably because of its convenience and more in keeping with an active lifestyle, whereas the older age group patients strongly favored IV treatment. And this was possibly due to perceived safety of a monitored environment and physician supervision. The key takeaway, again, is that route of administration should be individualized, as patients' preferences can vary, and that this can actually impact adherence and satisfaction. Slightly old data, but still relevant. The Danish DanBio registry evaluated the adherence and effectiveness of biologic monotherapy in rheumatoid arthritis. Approximately 1 in 5 patients receive biologic monotherapy. Importantly, drug survival, which can be taken as a proxy for adherence, was around 70% at 2 years, which is quite robust for real-world practice. Adherence was broadly comparable across the biologics, with one key exception. Infliximab showed significantly lower persistent, possibly reflecting problems with immunogenicity as well as infusion-related factors. Crucially, biologic monotherapy still achieved clinically meaningful remission and sustained response, suggesting that combination therapy is not always required for effectiveness. And again, overall, this data supports that biologic monotherapy can be a practical and durable treatment strategy, especially in patients who cannot tolerate methotrexate. Data from a large US claims-based study evaluated adherence and costs in over 10,000 patients with rheumatoid arthritis taking biologic therapy, initiating biologic therapy. And the key finding here is that adherence was suboptimal, only about 46% at year 1 and just 34% at 2 years. Importantly, adherence was strongly linked to treatment effectiveness. Patients who responded in the first year had nearly 60% adherence at year 2, compared to only 32% in non-responders. IV biologics were associated with better adherence, likely reflecting supervised adherence and structured dosing. Interestingly, higher adherence was associated with higher healthcare costs, driven primarily by ongoing biologic use. This qualitative study explored how rheumatologists perceive medication adherence in patients with rheumatoid. It found that clinicians rarely use formal adherence assessment tools, instead only rely on patients' self-report. And they use clinical judgment as well as disease control markers. But adherence was viewed as a multifactorial issue, which involves patient-related factors like their beliefs, fears of side effects and costs, physician-related factors like communication and education, and system-level barriers like access and time constraints. Rheumatologists noted that non-adherence is often underreported by patients, making it difficult to detect it in clinical practice. Overall, the study highlights that improving adherence requires patient-centered, multidisciplinary approach focused on education, communication, and simplifying treatment wherever possible. So what strategies can we use to improve adherence in patients with rheumatoid? Effective communication and active patient engagement tend to build trust, and they improve understanding of the treatment plan. Shared decision-making, or the concordance model, which we talked about, is particularly important, as involving patients in the treatment choices increases their confidence and their commitment to therapy. A multidisciplinary approach, including rheumatologists, nurses, pharmacists, and allied health professionals, can provide consistent education and reinforcement of adherence behaviors. And finally, closer monitoring of high-risk individuals or patients that can be more vulnerable will allow early detection of non-adherence and timely intervention, ultimately improving the long-term outcomes. Again, improving adherence in rheumatology also involves expanding and individualizing the treatment options, offering different routes of administration like oral versus injectable therapies can improve patient acceptability. Simplifying regimens through once daily dosing or longer acting formulations can further improve the treatment burden. Tailoring therapy according to patients' lifestyle and preference, while optimizing the dosing to minimize the side effects, also supports better long-term adherence. In addition, practical and technology-based interventions can play an important role. Simple tools like dosette boxes, pill organizers can help older patients manage complex treatment plans, while these days mobile apps provide reminders and tracking support. More advanced smart adherent technologies like the electronic pill dispenser and wearable injection devices offer real-time monitoring and can significantly enhance medication taking behavior. Patients should be educated about the consequence of poor disease control, including disability and long-term functional decline. Access to reliable educational resource and patient support groups can further reinforce understanding and engagement with therapy. At a broader level, health policy and socioeconomic support are essential. Reducing medicine costs, improving access to biologic therapy, and strengthening the healthcare coverage can significantly improve treatment continuity. Policy-level awareness and support systems are also needed to address structural barriers to adherence. Overall, improving adherence requires a multi-dimensional approach that integrates patient education, simplified treatment strategies, technology-based support, systemic healthcare, and policy intervention. So to conclude, how do we bridge the gap between therapy and outcomes? Non-adherence remains a major under-recognized barrier to optimal disease control in patients with rheumatic disease. Despite all the advances in conventional DMARDs, biologic DMARDs, and targeted synthetic DMARDs, outcomes are often limited by patient-related factors rather than the efficacy of the drug. So adherence is multidimensional, which is influenced by psychological factors, economic constraints, treatment-related issues, as well as patients' beliefs and awareness. So thank you very much for your time. If there are any questions, I'm happy to take them. Thank you. जी बिल्कुल नहीं, you're absolutely right. And मतलब दुनिया भर में तो पेशेंट सपोर्ट ग्रुप्स मौजूद होते हैं, लोकल लेवल पे आई एम श्योर लोगों के होते हैं इस तरह की स्टोरीज, टेस्टिमोनियल्स. We tend to advertise as well. And I was just speaking with Dr. Babar this morning, and I think even from a PSR viewpoint, I think this is one of the things, Dr. Babar, that you were discussing this morning, which is your idea of patient engagement. So I think patient stories are very important because doctors का मतलब obviously patient-doctor relation is one thing, but to actually hear from somebody who's taken something और वो improve हुआ हो तो वो एक real world example होती है जिसका के impact बहुत ज़्यादा हो सकता है. So thank you very much. Absolutely right. Agreed. Thank you.